So now you can see.
Yes, yes, yes. Hi. Get one. So when should we start?
Sorry.
When can we start?
Yeah, we can start. No issue.
Okay, so then fine, sure. Um, can we
So,
please?
sir, uh, ma'am, it is okay if we can continue without video.
Yeah, sir, sure, not a problem, sir.
Okay.
Yes.
So, I'm making the session live.
Okay, sir, thank you.
Okay, sir.
Fine.
Recording in progress.
So are we live?
Yes, ma'am.
Yes, okay. Good afternoon, everyone. I am Dr. Snehal, and on behalf of IDA, I would like to thank all the participants for joining today's webinar on Pathfinder, a digital implant solution. I would especially like to thank Dr. Anshul Mel for taking time out of his busy schedule to share his extensive knowledge on digital implant solution with us. Dr. Anshul is a highly accomplished master in prosthodontics and has been a pioneering digital dental expert since 2014. With an impressive 8 patents and 4 copyrights in digital dentistry, he stands at the forefront of innovation in his field. His contributions to the dental science are widely recognized through his extensive national and international publications in various prestigious journals. In addition to his research and development work, Dr. Anshul plays a vital role as a key opinion leader for several national and international companies. His expertise is sought after globally, significantly influencing the direction of digital dentistry advancements. Moreover, as an official trainer for ExoCAD, Dr. Anshul imparts his vast knowledge and skills to dental professionals, furthering the reach and impact of the digital dental technology. And I'm requesting all the participants to please put their speakers on mute. And the question answer session will be taken up in the end. Over to you, Dr. Anshul Mel. Thank you.
Thank you, doctor, for introduction. So good afternoon, everyone. Today I'm going to start on a digital journey. I can say the short journey which I have go through from 2014. So my first thing is like everyone we are staying in the digital world. Even right now we are doing this meet also digitally. So everywhere we have cater with the digital. Okay, so digitalize it starts from long time, and it is surrounding us day to day life. Okay, so I'm a Dr. Anshul Mel. I'm just presenting some of the things which we are doing it on a digital dentistry, and maybe like it will help you out to update your things from routine practice to the next level with to get the quality work or accurately output for that. So basically we start our journey. I just give you short introduction, like okay, so we like I'm giving an example of letters. Okay, earlier we are just the transferring the message, we are using this. Then later like we have post and all, like we are posting couriers and all, we are doing it. And now we have a completely gone like everything in your hand. So yes, just you want to text anything, you can easily text and you can send it to the end user directly. So this is how the like progress in the simple way of later messaging we are doing it. And the same way in our digital dentistry also it's going to happen. Okay, so it's like worldwide we are connected with everyone, and then we can do it. So this is the complete things we are like gathering with that. But only problem is like example we have a mobile. Okay, we are using different applications, but now like example Facebook or the Instagram. Okay, now 2 or 3 days I'm getting on one post like don't use this, this is not pirated or the hacked profile, it is not my original profile. So on only problem what I'm saying is like the guidance. Okay, we are using it, but we if you have proper guidance and proper understanding of the technology, you will not fail to get the proper output from that. So it is most important to use the technologies compulsion nowadays. Plus, along with that, you require proper path also. That's why my today's topic is on pathfinder. Like you should have a proper path, utilize that technology. And if you understand the technology, this thing will not happen. If you understand your example, your husband and wife both understanding the things, this thing not happen at the end of the marriage. Okay, so so like that, if you know the proper understanding of technology, you will definitely use the digital entities. Otherwise, you will keep it aside and you will use normal manual technology, and then you are not upgrade with the time. So I will just brief idea like CAD CAM have three parts like scanning, designing, and the milling like a cam. So every day I'm getting the calls from the different doctors like which scanner is good, which one to buy, which have more accuracy, this have that, and like the which milling machine I should buy. The laboratory guys are calling me nowadays like. So I will say like complete CAD cam is like, if you ask me, the heart of CAD cam is CAD. Okay, the CAD, no one is concentrating on CAD. So CAD is like whatever work you are doing or whatever data you are giving to the software, we can analyze in the CAD. It is useful or no, that we can utilize for our manufacturing process like CAM or no, and it is suitable for your CAM or no. So everything you can do in CAD. So basically, yes, definitely, which scanner is important. Like you have better accuracy of scanner, you should buy that scanner. Or along with that, the buying the high quality scanner, along with how to drive the scanner. Okay, how to use the scanner, that is also most important part. Even sometimes we have not that much of quality of scanner, then but you know how to drive it, you will get much better data than someone who have a high accuracy of scanner, but you don't know how to use the scanner. So that same way, the cam also, like you can have a high end of cam, but you should know how is your design. Okay, how you have design, like it is suitable for your cam or no. So this is complete inside of the cam, cat cam designing part I'm just exploring you. And today's topic is on implants. So digital implantology will start from the not from the starting from the scanning, it starts from the planning. Okay, like how you plan your case, how you place your implant, and then what all possibilities are there after that, that you can relate. So CAD-CAM in digital implantology will start from selection of patient, and then you further like placement of implant guided, then scanning, and then prosthetic manufacturing. So first I will start with the guided surgery. Okay, so the guided surgery, like how the bone is there, like which size of implant we can place it, where exactly place it, what all prosthetic components are there in that company we can utilize, or we can plan according to that. So that's lot of area like guided surgery is giving us, which is not there when you are planning free and like just seeing the CBCT and just thinking or just placing in a 2D software is you will not get that much of idea of the final output. And for the patient, it's like only final output. Okay, they are not seeing the things like what you are doing inside of mouth, they are just seeing final output, how it's look, and patient is having have a food or no, like domestication should be proper. So these two things is most important, and which helps guided surgery to you, you can plan everything. So mostly guided surgery, you plan the implant, and there's a guided guide, so you can use it for the drills, and like you can place the implant particular what you have planned. Like it's called prosthetic driven implantology. So same way, if you have temporary pickup prosthetic, you can utilize to pick up the implant abutment and modify and create proper emergence profile. And Yeah, definitely. If you want to do mock-up surgery before final output, yeah, you can do that also. So this is a simple three parts of the guided surgery. Like normally we can do it, but it looks very easy. Like you can place the implant, you can give immediate smile, everything you can do it. But the most important thing is like this. Before marriage you require proper biodata. Okay, like same way, the same the guided surgery, you require proper data, otherwise this thing's going to happen. Okay, so that's how you can use the data properly, otherwise it create lot of problem, and it is like you never use the guided surgery after that. So it's important to use the data, and the select the data and selection of patient is most important. So we just do a three. Commonly, we are just gather the data in three ways, like partially edentulous cases, okay, in which like the intraoral scan or cast and the CBCT data. But in that, most three common problem which I am noticing is like when I'm getting the data, if only one molar is missing, people are taking CBCT of just adjacent teeth, like first premolar and the second molar. Okay, so it is not helpful for the superimposition of clinical cast, because CBCT give you only bone. Okay, and clinical condition, when you are giving to the doctor or like the guide manufacturer, they want to transfer that clinical data, they require the superimposition area like lot of teeth, so they can match and you will get the better output of that. Okay, and the same problem when you're screening on the screen, like so you are in area of interest is like edentulous area, but next to that edentulous area there is a restoration like metal restoration or zirconia restoration or any kind of restoration is there. It create artifacts in your data, and they will do directly, they will send me and ask me to give a guide, and it is actually not perfectly fitting inside of mouth. Then they will call me like, what doctor, what happened, like why you done it, and we ask them to modify the data. They are not ready to modify, like patient cannot pay second time. So be careful whenever you have this kind of things. Okay, you should take your data with the prosthesis. When it is there, you should create the marker as you can see onto the screen. Okay, you place the marker and then you can send patient for the get capture in the CT scan. So you can see in this image, even though it is artifacts because of the restorations, I can see the markers, I can superimpose the things. So these things like very small, but it is more effectively we can achieve it. So that's how, like example, if you want to go for the photograph of your profile or for the passport, you get ready. Okay, then you get the proper photograph of that. The same way you require proper data for your guided surgery, then only you will get the perfect result. Same way in partial edentulous, if you have a unilateral like this long edentulous area, yes, definitely you should create the removable prosthesis only in acrylic. Okay, only in acrylic, and you can place the marker and then ask patient to take data in the closed mouth. Okay, so this is the most important data gathering for partial edentulous cases. Then complete edentulous cases, in which like you create the denture, upper and lower denture, and then place the marker like as you can see on a screen. So like you can superimpose later on. Now so many doctor asking now why we want denture, why we want to create denture. You can directly read the guide on it. So first thing is like denture give you a rough idea where your future occlusion is going to be, where the patient have a occlusal plane, midline, smile line, and the most important factor which is common in edentulous cases when you place the implant and after that you struggle is the important factor is uh, patient is not giving proper occlusion when you start to create the prosthesis. So this denture will give lot of idea like what kind of implant, how many implants, like how which kind of implant you should plan, or you should trim the bone to get inter space or not. So all idea you can get it from the denture. The and most important factor when you send the patient for the CBCT or CT scan, your denture should be in occlusion. Okay, patient should wear that denture and it should be in occlusion, and then you capture the CBCT. So this most important part when you capture edentulous area. with the complete denture. Now the question is like so many doctors don't want to create the denture. They don't want to invest the money to acrylize the denture. So what they are doing it, they are sending me the data with the denture base and trine. Okay, trine state they will place the marker and they will send it. So what common problem we are facing in a trine stage? Yeah, there is no issue in midline, smile line, occlusal, whatever the guidance we want. But only problem we are facing is like they have used the shellac denture base, okay, or they have used a light cure denture base. These two material are radio opaque in nature. So when we do a CBCT or CT scan, you will see on the right side on your screen, you will get this kind of data, and which create a lot of problem while planning. And we are planning on the soft tissue, we cannot take out the soft tissue from our data. So this is the most common thing we are facing, and this data this point should be keep in mind while sending this kind of data to the guide, or you are looking for the data for the full mouth guide planning. This thing is most important part. And the last but very rarely you will come across this kind of condition which like you have completely edentulous cases, okay, like same ways you have complete edentulous cases where you have to extract the tooth and then you have to place the implant. And this condition will when it happen, like you have all mobile teeth, okay, if you have all mobile teeth in patient mouth, and if you take an impression, okay, then the teeth position is different, and when the patient is going for CBCT, the teeth position is different. So when I'm matching the both the condition, it is difficult to match inside of software because both have different position. So in this condition you apply the composite or thin wire on the backside and split the tooth with the composite. So everything is going to be stable on a one position, then you scan it, or you can take an impression, or you will then you will send it for the CVCT. So this is most important factor in completely dentulous cases. Now the most second part is like type of guide. Like some of you are hearing about pilot guide, fully guided. Then also like we have different system. Okay, like the some of the system give external sleeves with the handle, so you have to hold the sleeves with the guide and then you have to drill it. Then some of the system give the sleeves which is topped inside of the another sleeve, so you require multiple sleeves while surgery. And the third most common is like master sleeves is given by the company, and you have a huge number of drill set, so you have to coordinate the size, and according to you change your drills. Okay, so drills have a guided area and the drilling area, so according to that you can select the different drills to do a drilling. So first system in which like you have external key, only problem is like advantage is like you can use your freehand kit also, but only problem is like you have a three parts to handle. One is inside of mouth the guide, second is the sleeves, and third one is like your drills, okay, which don't have a like guided areas. And even though it have a play also, because we have to give little space to rotate it inside of the sleeves. So that is most important part in which you can any stage you can create the like a problem, and it will go in different direction. So this is very difficult and tricky to use this kind of guide. The second guide in which like you have a different sleeves, okay, so that sleeves you can utilize it for one case. Now you want to utilize for second case, not feasible because you have already cut according to the distance of tissue and in between the tissue and the guide. So it is very costly system when you are looking for the guided surgery. And third one is like master sleeves, in which like you have one sleeves is there, and then you want to drill it, okay. So only problem in this when you are on a back side, okay, like this molar area. So in molar area what you have to do, like you have to go from occlusal area to the down for the do a osteotomy, okay. So you will not get entire space for the guided drills because it have a little guided area also, it is longer compared to that regular freehand drills. So you will not get in between the antagonist teeth and the guide, you will not get a space to go from the top. So one more system is called Ostem. Have launched this system is sleeveless, in which like you have a lateral opening also. So from side you can go inside. So you will save almost 10.5 of distance, and like it makes you to do this kind of surgery like very easily. So this is a advantage. Now some of the system have launched that metal sleeves with the cable cut. So do you have both advantage, like you have a perfect size inside as well as the path to go from the buckle, and then you can go inside. So you have the mouth opening is not restrict your osteotomy. So guided implant placement, that is also most important part, and the selecting the guide for the particular condition is most important part. Like tooth and tissue supported, most commonly like you have a one tooth missing, you place the guide, you can drill it, okay. And it is definitely more precise because your teeth is connected with the bone, so you have a complete reference of tooth to stabilize the guide, and you can finish off the surgery. Okay, the same way if you have full arch cases also you can do it. Example, you have a lot of teeth in upper, you can see, but you are not placing the tooth single implant at the same position of the tooth. Okay, so you can, what you can do with the teeth, you can able to preserve that, you can preserve and utilize to stabilize your guide and do a guided surgery. The same way as you can see, we have preserve on central and the two molars, and we stabilize the guide, and we done a guided surgery. After surgery you can remove the teeth and you can finish off your case. So the teeth will act as a reference to connect your surgical guide with the osteotomy. So it's give you a perfect result after surgery. So that's how you can do for full arch also. It's called tooth and tissue supported, but yeah, definitely it's like extraction also is there and placement is also there. So you can utilize both concept and you can get the precise output of your guided surgery. Yeah, now why we want the guided surgery? Okay, the same way like tooth and tissue supported area, it's like most of the doctors are single implant is there, they can place easily. They will get perfect parallelism of from the occlusal forces, they can plan it. In anterior area, they will place the implant like that, so they will not get the screw channel from the buccal side of the tooth. Okay, but some of the challenging cases like in which like there is no bone on a labial side and you want to do a guided surgery. Okay, so in which like partial extraction therapy, okay, it's very difficult to judge where to you have to insert the implant. Sometimes your cell will come out or your implant placed palatal side. So in this condition, like guides are most commonly used and acceptable, and I can say must, you should use that according to my experience. So I'll just share this case in which like a doctor is looking for the partial extraction. So commonly, like from the center of the root, the this kind of section is doing. So like label shelf will intact and palatal side they will take out and they will place the implant. But only problem is that my implant profile is like this round. Okay, so when we start inserting implant, it will create pressure onto the label shelf, and there is a chance it will come out while placement. So it will create a problem, like because there is no bone now, you have to bone grafting and everything you have to do it. So if you want to preserve and you want to give a perfect pitch in between salc and then we require this profile. Okay, so like you have perfect pitch as well as the you can preserve the buccal salc, and you can maintain the angulation, and it should not move palatal also. So all criteria we can if we want to achieve, we can use this guided surgery. So it's give you a very like perfection in your result. Example, like this is the same case in which like we want to place the implant on the palatal side of that shelf. Okay, and along with that we want to take out that shelf also. So what we have done it, we created a proper four guides. First guide is like we use it to get the center of my osteotomy, like where I want to place the implant completely. I will go through the tooth and do a drilling, so I will get the perfect center of my osteotomy. The second guide we created for the point where we want to create curvature, okay, for the mesial side and the distal side. And the last is like normal guided surgery, what tooth and tissue supported we do to place the implant. We have created the final guide. So central guide is used to get the center, as you can see. Then the distal guide will give you the punch on a distal side. Then the mesial guide give you punch on a mesial side. Then we connect these 3 points and we take out the palatal part. Okay, then we take out the palatal part and then we use the guide to place the final implant, do a proper drilling and insert the implant. And same they like we can give a prosthetic. So we created the temporization because it's aesthetic zone and we want to create emergence profile as well. So this is the thing of the same case. The same way, like this is the only case in which like we have done a partial restoration. Now we got a case in which we have extraction, then followed by implant placement, and the same day we want to do immediate loading. So in that, and that is also like we can do a flap place, okay, but some of the area we have extraction, so you can easily see the bone and we require the suture in this case. So this is a case in which like we plan, you can see the some of the teeth are present in the patient mouth, plan it, and we create the stackable guide. So in the reference of teeth we stabilize the base guide, as you can see a sky blue color on a screen, okay, before extraction of teeth, because we want to create the foundation. Because once we extract the tooth, the extraction area will not match my clinical condition to the like what I have done in software, okay, and it will not allow my guide to fit perfectly. So that's why we want foundation to be created before extraction. So we use the stackable guide. So this blue part and the green part together, which retain with the screw retain, like it is fixed with the screw. So when we it, and then after fixing with the screw it become one part. So in a reference of that we place this guide inside of the mouth, and then drilling guide which rest on my foundation, and then my prosthetic is ready with the help of that foundation. So it has four parts, like the splint what you are seeing on a orange color, then the splint in metal color like the base guide, then drilling guide, and then the prosthesis. So clinical side, this is my condition of the case on that day of surgery. We utilize that teeth to stabilize my guide, and then we my base guide will use the anchor pin which connect my guide with the bone. So my guide is now stabilized in the reference of my natural teeth. Then you open the screw of the splint, so you can see my base guide, I can able to see inside, and then I can see my teeth. So I will remove all the teeth which is there below that, and then I will use my drilling guide and which is screw retain on my foundation, the base guide. Now I will do a drilling and implant placement through that this guide. After placement, I will place my multi-unit abutment, I will place my cylinder, and a help of my base guide, I will pick up my prosthesis. And this process is made from crown and bridge resin, which help to give a proper strength to that for the long time. And then we take out the extension, we polished the some of the area, we take out the excess cement and reinsert on the same appointment. So we'll get immediate prosthesis, extraction, and everything on the same appointment. So this is and there is no need of jaw relation, because pre-operative we have a teeth, we take a reference of that for the jaw relation as well as midline and occlusal plane. The same way, like there is no reference in Edentulous cases, okay, to stabilize my guide, because when we are stabilizing my guide, okay, no common thing is like we create a denture, okay, the denture have integular surface, but when we stabilize the guide inside of the mouth, okay, we use that same surface to stabilize it, but it is resting onto the soft tissue, it is resting onto the soft tissue, okay. So when we do a fixation of guide with the soft tissue, it will tilt the guide on the right side. Example, if I will use anchor pin and I will use to stabilize my guide and do it on the right side first, it will move my tilt my guide onto the right side, as there is no torque value how much the torque we have to, because it is resting on the soft tissue. So you the n number, if you are inserting, it will go still, it go inside and it will tilt my guide. So that is a problem most commonly we are facing, and we started this surgery in 2017-18 and we face this problem. So what we have done, we done one analysis, we place the guide and we send the patient for CBCT with the metal housing inside, and we seen like my metal housing is outside than the reach. Okay, what I have planned, then we analyze like what is the problem. When we have stabilized my guide onto the soft tissue, it create a lot of problem in edentulous cases. Either you require the natural teeth in one of the arch which guide you, which give you a reference to stabilize your guide if you have included the occlusion inside of your guide, or you have to create the bone level because it give you a rigid reference to stabilize your guide. Okay, so this is a most common condition in edentulous cases. And as I told you previously, like denture give you a lot of things, the details. This is a lucky case by for from Dr. Abhishek Kaulekar. In this, like he got this case and he's seeing like a lot of bone is there and he wants to start the surgery immediately. But suddenly he feel like I should go try the guide first time, and he sent me the data. Then I got this data with the denture with CBCT inside and uh, um, the DICOM file of this denture, and I superimpose both the file inside the software and I'm seeing it. I have a lot of bone inside of this, but only problem is like that is like there is no interest space for my future prosthetic. So this is the only thing which I noticed, and I called him like say like, "Hey, brother, there is no bone uh, interest space to give a proper prosthetic later on. You have a lot of bone and which create a lot of problem when you going for the prosthetic. You require bone flattening and you have to place the implant at the lower levels, you will get proper interest space. So in this we decided to do a bone cutting guides on a level. Then this is my bone cutting guide. Then the drilling guide, which is screw 10 on a base guide, it's on a bone cutting guide. We place the implant through that, and my metal acrylic prosthetic, which is ready before surgery. So everything is planned before surgery, and like profiles and everything is given. The below of the process is to like you will get like proper profiling after the healing. So this is a preoperative condition. After flap opening, we place the guide. As you can see, guide, because like we have to do bone flattening, so I require more flap opening, and I have to trim the bone till that level. After bone flattening, we'll get this position. Then we screw retain the drilling guide, and you can see I can see my all side, the coolant, everything I can give. I can take out debris, I can open my top part and I can see the osteotomy, all possibilities I have in this guide. And this is the osteotomy. So it's the most important part, like you use the drill step by step, don't jump the like the freehand. Example, you have 4 by 10 of size of implant, most commonly initial, then 2 by 10, 3 by 10, 4 by 10 people are using, but in guided surgery you require 2.2 by 7, 8.5, 10, 3.5 by 7, 8.5, and like sequence wise you have to do everything. And the you can see on my screen like my previous ostomy is guiding my drill. So I my drill have two reference, one is sleeves and second one is previous osteotomy. So that's how we can do a drilling. And the same way the implant insertion also through the guide, so like it will not deviate the position, and it will match the abutment position what I have decided in my software. So this is two important part which is required in guided surgery. So after implant placement, doctor place the multi-unit abutment, then the cylinders, Then the reference of the master guide, he doctor have pick up the cylinder. So routinely what happen, like when you have a pre-operative denture, we make a hole and we pick up the cylinders. At that time what happen, like it is resting on a soft tissue, so we ask patient to close the mouth, is not closing the mouth properly because all GA or LA, sorry, in LA is given, so it's not able to close the mouth, and all trauma of the surgery is there, so it's not giving proper occlusion, and it create deviate my occlusion inside of mouth. Okay, the second thing is like interior surface also modify because I have opened the flap. Okay, so this is the things like there, if I have prefabricated denture and pick up, because there is no rigid reference to pick up my cylinder, but this guide give you a provision of three studs, so in the reference of that I will pick up the cylinders and there is no need of patient to close the mouth. So this is the advantage of this guide. After pick up the cylinder, we just cut off the three extension and reinsert. So this how we can utilize the complete guided surgery for the edentulous cases, and immediately we can give the uh, prosthetic to the patient. Okay, but it is not always like easy. Okay, as you can see on a screen, okay, it's catch is easy, but it is not easy and okay, as the same way, if I am a planner of your case, everything is not in my hand. You have to understand the protocol and you have to understand the digital technology, how it's working. It is not always we can do a fully guided or the same cases what you have seen. It depend on case to case, we have to select the guide as well. Okay, example, this is the case in which there is no worry about the placement or the doing the surgery, but only problem is like if you want to plan it with the prosthetic driven, as you can see in OPG you have lot of bone. Okay, but if you see in CT scan, the profile is like the S shape. Okay, and if I want to place prosthetic beyond the straight implant, then if it will perforate my lingual plate, so that I don't want. So in that condition where you have a indirect sinus lift or you have a canal and limited bone, you want to do this kind of surgery, we recommended to go ahead with the bone level. Okay, so you will get 100% better result. The same way, if you have a direct lift and where to create the window you want to analyze, definitely you should go with the bone level guide and you will achieve that result. So, and yeah, zygomatic implant, in that we have to open the flap till the zygoma, as we have to uh, do a trans sinus. Okay, so we have to open the flap and we have to take out the lateral wall of my sinus. So this is a guide what we have created. The first guide will help you to tunneling, and the second guide is screw return on a first guide. So step fix, do a do a flap opening, place the guide, do a fixation of guide. As it is on a bone, it will give up 100% placement onto the bone, and this we can get it from CBCT or CT scan for the profile. So it has a complete reference, give you the perfect reference file fixation of guide. The second part is do a lateral drilling through the guide. After drilling, you will get the slots. Okay, after that, the top part is it's screw ten on the bottom part, so it create complete ring. Okay, complete sleeves for to insert your drill. Then you can insert the drill. Okay, so you don't require separate two guides and they take out the first guide and check place the second guide and do a drilling. You will do a drilling through the guide, then take out the insert the implant through the guide and the match the position, the flat wall of my tool with the flat wall of my guide, and match this position. So which we have calculated the multi-unit abutment, so like directly you can place on that. Remove the guide, and what we have decided the multi-unit abutment, directly we will get it through the guide. So this is the advantage of guide with minimum problem of placement and less surgical time. But only problem we are facing when we are doing using this guide on a posterior area, patient require a lot of mouth opening when we are looking for the posterior area. So we modify our workflow, we modify our guide. We created the second guide onto the top of our guide, which is top level, like the B point. Okay, so like directly from there you can insert the drill and you will get. So this much of distance we have covered in the second guide. So like there is no problem in mouth opening. You can easily place the implant posterior as well. The last option, like in implant supported guide. Okay, nowadays like a lot of cases we are getting in like second inning or third innings of that case. Sometimes like a patient have placed the two posterior implants, now a requirement of anterior implants. So in that condition we take a reference of implant as well as the remaining teeth to stabilize the guide, because in this condition the implant and the tooth both are connected with the bone, as well as the advantage of like we will not get the anchoring pin, like we will not get the space to anchor the guide. So that's how we started to do implant supported guide. So in this case we use posteriorly the implant to stabilize the guide, and anterior the natural teeth we kept it and we do a guided surgery. So this is the thing when we have implant as a stabilizing the guide. This is a unique case in which like anterior implant already doctor placed, now the posteriorly he want to place the implant, but only problem is that the very limited bone, only 6 mm bone, and there is no attached gingiva on a posterior side. Okay, so it's very resolved. Okay, so like it is very difficult to, there is no attached gingiva, so very difficult to open the flap. So doctor want to do a tissue punch and directly want to insert the implant. So in that condition, what we have done it, we make a jig while CBCT, which is radio opaque, and do a CBCT with the that jig, and then utilize that jig to fabricate the guide. Okay, so now my anterior guide is stabilized with the implant, and the posterior area where there is no attached gingiva, I cannot stabilize my guide. It is screw written on anterior part, and then a doctor have done a tissue level surgery. So this kind of cases we can do it in this condition when we have a implant. So that's how like first part I am just little brief I have just explained for the guided surgery. Now the second and most important part, which is uh, the heart of the CAD CAM, I can say, the selection of system, selection of abutment, and selection of digital workflow, which is most important part in CAD CAM. So the scanning, okay, how you scan it. The second part is like you have a, you place the implant, now you want to scan the implant area. So now the scanning is the second most part. So it have a like in open tray and closed tray you have transfer coping. In digital workflow you have a scan body. Different scan bodies are there, and according to system, or you will get it from third party also, which is compatible with the original system. So you can use this scan body to scan the area, and same way when we have open tray and closed tray impression transfer coping, and we have analog to port the model, the same way we have a digital analog which is compatible with that scan body, and you can use that scan uh, analog after creating the model from the software. So this is most common thing, like when you selecting the scan body, it is there a digital analog is there or no, and what all things we can manufacture using that scan body. So like it's supporting the tie base or no, like it pre-mill or no, that we are seeing in a later of this presentation. Okay, so the most common question like I'm getting like single two implants sir, I will get the scan. Okay, and it is we are getting the implant like result also, but full arches sir we are not getting the result. How to scan it? So for that we have make some small tips how you can scan it. For upper, yeah, definitely there is no problem, because maximum time you have a attached gingiva, so software will take a reference to scan it. But for the lower, okay, for lower, lot of people have a problem to scan it, as there is less attached gingiva and lot of mobile tissue. And scanner, how the scanner is working, scanner throwing the light, reflection of light, it will capture and it create the imaging the simple way. Okay, so it means it requires the static part, so like the reflection will easily capture. Okay, and in lower there is no attached gingiva, so you will not get much static part to scan it. So in that condition what we are doing it, we just place the scan body, we attach with a floss or maybe rubber band, and this is the scan body from Bark. It's a third party solutions. So like you can place it on multi-unit abutment and you can scan it, and then it easy. Sometimes the case is like free fibula done and lot of soft tissue paddles are there. In that condition, we just flow along with this scan body, we flow the light body also and scan it, and after that we take out from the mouth and then rescan it inside of the laboratory, and then we superimpose and create one structure. But it is only necessary when you have a lot of soft tissue inside of the patient mouth. So this is one workflow we set for the scanning of the lower arch, and then we just design the denture base with the marker, and we just normal jaw relation we do it, and we can transfer the data. So directly you can superimpose the old data with the new data and you can directly get the jaw relation. So that's how we are doing the jaw relation as well digitally. And if you have a like immediate loading, you have done it with a prefabricated denture, okay, and patient is happy with the midline and smile lines, and what you can do it, you can place, you mop the palatal area, you place the composite ball only, okay, like flowable composite. If you use it, it will stick once you mop the area without any bonding agent, because it's a dry, and if you use it with the uh, flowable composite and cure it, it will stable. Other option for that, you can use ortho implants, small implants are there, you can, or maybe you can use oral surgery like plating screws also you can use on a palatal side, and then you can start scanning with the prosthetic, okay, where what you have already given on to the patient on a left side of screen you can see it. So first scan upper arch with the prosthetic with the marker, and a lower scan, then occlusion. So first set of scan have upper prosthetic, lower prosthetic, or maybe teeth and the marker, and the second set of the scan, you take out the prosthetic, place the scan body, and then scan it. So like you can superimpose both the part with that scan for the previous data, and you directly get the occlusion. The same way, if you have a lower and you have done bone flattening, so after healing, what happen, like you will get the recession, like the space. Okay, so in that condition, what you can do is you can flow your light body below, and you can send it to the lab the complete prosthetic. So like they can pour the cast with the analog, and you can utilize, along with that they will do mounting also, so everything you can finish. The second option is that it's called an analog scan body, okay. In place of placement of analog, you can use the scan body and scan the integral surface. So this reference, you will get the upper, like the prosthetic will give you occlusal plane, the position of teeth, and the back side will give you the soft tissue and the implant position. So like first scan will give you the scan body, the second scan is give you the occlusion, and both you can superimpose and design in the software exocad, like you will get this complete information, and like you can directly mimic the processes what you have given for the temporary, and whatever editing you want to do, you can do that also. So like this you can get the result for the final. But only problem is that you got the data, you with the scanning, you place the implant with the guide surgery, but a lot of doctor I have seen, they are not selecting the abutment properly. Okay, so that's I want they can level up their practice, okay. The abutment selection is most important part in all systems, okay, to get the perfect output of the prosthetic. So if I ask, a lot of people will say me like the open tray and closed tray, open tray for the full arch, and the closed tray like for the like one or two implant we are recommended the closed tray. But only problem is that after taking a impression, how you analyze it. So everyone say like we are creating the jig and we checking the jig, okay, and they will send it to the lab like is fitting, and after that the metal or any pfm prosthetic or mill prosthetic not fitting inside of mouth, and they say like my jig was perfect, and your process is not perfect, and that's why it's not fitting. But not like that, it is most important part, like the which kind of jig and which shape of jig and which component you have used to check the jig. Okay, if you have only like full large cases, and if I will give you a jig with the hex transfer coping, it will not going to fit definitely. Okay, and if I have a jig, okay, in C shape as you can see on a screen, and if I will send it to you, and it has a flexibility like most of the lab are creating pattern resin. Okay, so it have a flexibility, it's a resin. Okay, it is flex and it will fit inside of mouth. But in place of that, when what we have done it, whenever you have multiple implant, and definitely you are going for a non-hex for the abutment solution. Okay, in that condition, if you want to check the jig, what we are doing it, we just give a non-hex scan body jig with a non-hex component, and we are giving for lower A shape and upper D shape. Okay, so when we transfer or placement see in placement inside of mouth, it will not the flex, and if it is not fitting, it means or your measurement is wrong. If it is fitting, it's perfect. But if you are not making this stop, it will flex like this and it will fit. Okay, so this is most things like I'm seeing. So just little brief I'm telling like how we are attaching this with the jig trial. And like always I'm seeing like this is a photograph when I have a catalog of company. Okay, they have a lot of abutment inside that, and when you ask your laboratory, they will tell you like you just send me the straight abutment, angle abutment, castable abutment, and multi-unit. That's it. Four abutments only they will ask you. Okay, and the company is investing so much of money behind the creating lot of abutment solution, and it create huge catalog for the prosthetic components. Okay, so why they are investing so much of money behind the getting the proper solution. So that's why I am always remember this thing why they are making. So if I will say all are straight abutment, okay, straight stock abutments. Now all have different profiles. So I have always questioned why they are have a four different straight profile, when to use, which one to use, and how to use it. And that's how selection of abutment is most important factor. So most of the time when we are looking for the implant prosthetic, we are planning metal, ceramic, or zirconia. So definitely we require the shoulder. Okay, very few condition in which like we are planning for the metal as a chamfer finish line. So simple way, if I will say the first one on our left side and the last one on the right side, if I will looking for that. Okay, both have differences like the left side have a chamfer finish line and the right side have a shoulder finish line. So according to that, you can switch your processes. Okay, the second most important part, if you can see left side, the first which have a serration inside of that. Okay, that serrations like give you a mechanical retention, and the right side also it's there, so it like cement retain. If you are going to do it directly with that, you can do it. Then I have always questioned why they are giving this the polished surface abutment. Okay, then we realize that there is one more option in which you can use the stock abutment, you can convert it into the custom abutment. The software will give you the provision like you can customize it. Okay, so that's how they are giving the polished surface, so you can utilize as much as surface in your customization. And and in that we have provision of in software like you can decide the cement space. So what you have to do, you have to keep very less cement space because it's completely polished. You place your abutment, like you can design your abutment, you can cast it or mill it, and or 3D print it in the metal and just place it onto the abutment, just tap it. It should be completely friction and it should directly tight with the abutment, so there is no need of luting two abutment. And if it is not luting, it means it's a cold weld and it will not create any problem later on once you fix it. Because if it is loose later on, then on a top, even though you have to cement the PFM or the remaining material. Example, you have four implants, then you have a 12 6 to 6 complete bridge. You have to cement that also on a top of it. But four have a different direction, so you can customize the abutment using this stock abutment. Okay, and then you can easily cement. So that's why the four straight abutment have a different indications, like if it is crown and if it is a PFM, then it is a hanging surface and create a lot of food lodgement. And there is after brushing also it will not go from that area because there is a hanging surface. The same way in the angle abutment also we have the problem. And along with that, the company is giving pre-mill abutment. Okay, this pre-mill abutment we can utilize in CAD/CAM technology. You can create your custom abutments inside of the software, and the connection, the junction between implant and the disc, it's already built by the company. Okay, so it's a calculated value which is given by the company. So you will not get much problem after doing the things, and you can make it digitally parallel with each other. The same way, this one more abutment is that you have a lot of wall thickness is there. So you one more milling machine we have, it's called surveyor. Okay, in the hand milling you can do, you can mill it on in your surveyor, and then you will get the parallelism. So these also options I just explore shortly in for the cement retain. Now the screw retain. So most of the things like laboratory asks you the screw retain. Okay, and they will say, doc, you send me with a tie base. Okay, so and after casting, they will see there is a difference in the position or difference in the fitting of the tie base with the implant. Okay, so always look into that. Tie base will never, you should never cast in our chrome cobalt or nickel chrome metal, as because it is react with the carbon inside of environment. Okay, so always when you are going for the casting, you should, if you ask the tie base, then you have to do titanium casting, or if you are going for the this one, the chrome cobalt nickel chrome casting, you can ask your company chrome cobalt or nickel chrome base. Definitely all company have that. Okay, but you have to ask them before that. So this is the thing you have to keep in mind. Or if any company don't have, then go ahead with the plastic abutment in place of any cylinders or any base in with the abutment. And always we are preferring the hex in comparison non-hex. Okay, but as you can, you know, everyone know, like if you have multiple implants, then it will not fit because it's not zero zero parallel, and your prosthetic will not fit. But hex have one advantage, like on a lateral forces, the hex will also have a support of wall of implant and the screw. So there is a two things which is resisting the forces is like the wall of the implant and the screw. But in non-hex, there is a plane between the wall of implant and the internal surface of the abutment. So maximum load will go with the internal screw, and there is a maximum chance it will bend, it will fracture, or it become a cold well inside of that. So that is a problem with the non-hex abutment. But as we know, like we cannot use hex in all implant if you have more than one implant. The same way, if we have a more than one implant, and if it is little tilt in the implant, a hex will go in the same position only, but non-hex will go in different position. If you can see on a right side screen, there is internal surface of the abutment and the internal surface of the implant, they less gap and compared to the other side, and it will create the problem inside of the processes. When we fix the screw will not at the long center of the implant, and it will let go cross, and two or three rotation it will stop, and you feel it is completely screwed in. But the neck of the abutment is not resting on the finish line inside of the abutment, so there is a maximum chance it will get fractured inside of the body of the implant, like this. To avoid that, so many companies are creating, even the bioarchitecture, the company as well as the Edin and Norris also have this solution in which, like the base and the top and the common screw will connected with this. So advantage of hex which is connected with the implant, the top part is castable and digitally you can do it, which is non-hex, and the common screw will connect both the things with the implant. Okay, so you have advantage of hex, advantage of non-hex, and everything is screw retained. So that's how you can do it. And the bioarchitectures will provide you the top part with angles also. So like you will get parallelism. If you are going for the casting and do a parallelism, even though you have a different angle of implant full arches, you can do it screw retain. So you can see this is the implant on which the tie base is placed, and then the bar on the top of it, which is connected with the single screw with the implant. So now it is connecting with the implant with the hex, and top part we have a non-hex and single screw holding that. So it's a difference from the multi is like only single screw is connecting with the implant, and advantage of hex as well as non-hex both you can take it. So two implant, three implants, or full large in which like your screw channel is not coming out through the label side, you can utilize it this abutment. The same way Breeden also is giving, which is internal hex to internal non-hex. So like you can take advantage of hex as well as non-hex, and you can utilize single screw to stabilize the processes. So that's how whatever the correction you want to do in non-hex, you can do it according to path of insertion, and it will give you a 20-degree of correction after placement of the implant. So on a one side, so total 40-degree of correction. The say you can utilize that. And the last like multi-unit, the straight multi-unit and angle multi-unit. But means like you can get it the different angle. And digital abutment, it's called tie base. So like example, you want to do a complete zirconia, okay, you the zirconia connection you cannot give because it will get fracture. So for to combine that, the company created a tie base. So like you can design in the software, and you will get the integral surface in the processes which is similar to the dish tie base. So like you can directly fit, and company give different value of fitting, you can select according to your need. So directly you can mill the zirconia and do a screw retain processes, and whatever angle you want to correct, you can correct it on the top of tie base. So cement retain, I will recommend these three most common options, like you should utilize it. What I recommended. And for the screw retain, I'm just recommending these three options. So like you will get easily and perfect passive fitting, as well as the protection of your implant and the internal screw. And the same way, like we have overdentures, so like ball and socket and locators are there. And now the companies are coming with the angle locators also. So like you can utilize for the all on four cases, or maybe like uh, your implant is not in parallelism, then you can utilize the angle locator as well. But the reality is that after using that also, so many things, like so many doctors are facing the problem to get the passivity, even though they are utilizing complete digital as well as milling, everything they are done, it still lot of troubles are there. So simple way, if I ask the question, okay, so this is the condition in which one is tooth is missing, and if I want to create the bridge, both tooth have a different path of insertion. So what is the option? The simple way, you have to do a cutting in the one path of insertion, or you have to create a telescopic crown and you can give a bridge, or you can give a key and keyway. Okay, but same problem if I want to create the bridge on this two implant. Okay, if you can see, my both path of insertion is same, but the difference is that is in the finish line. If you see, the middle one have a perfect finish line with the up the first one, okay, but the last one, third one, is like the finish line is not matching with the first one. So what happen if I will create the cement retain crown on or bridge on it? When I will cementing, it will adapt completely on a one implant, and it will not adapt completely on a other implant because the finish line have different directions. Okay, but if I will use the second one and the first one, I will get complete adaptation all around. So this is the main advantage of selecting the abutment, as well as do a hand surveying, or you can select the system which pro give you this kind of solutions. See, this is the case, the simple case. Only one implant is not in much parallelism. Okay, so what happened? So just I will place the processes. I will just start inserting the fixation screw inside of the last implant which is not parallel. Okay, so when I will screw, you can see my prosthesis is lifting on other side, so it give you the impact like where when it is fitting, it is completely fit on each other as it is a conical. But when I will just start giving the fixation screw, it is start adapting with the finish line of that particular multi unit. Okay, and it will create the activation of my processes. You can see now I will press and I will screw it, so like my lot of load will be there on that previous screw and it will get fracture. So what internally is happening, like I have a two implants. When I will place my process is passive, and so many videos I am getting like, see, I will mill, so I got passive, but no one is showing with the fixation screw. Okay, wow, she feels stays. Okay, once you screw on a distal end of the implant or any one implant, it should not lift your other side. Okay, because the multi-unit is a taper, so taper to taper it will fit as you can see on a screen. But when you start screwing, or when you finish off the screwing of that area, it will start adapting to the finish line of that particular multi, and it will start lifting on other side. So this is the actual problem. No one is telling about that. Okay, just saying like it is fitting perfectly, and then they are not showing you the fixation screw. And if I will give a pressure and give screw and I will take OPG, yeah, definitely I will get my multi units is fitting, but it is in completely active forces inside of that processes. So simple question, how to correct. The first one is you make all multi-unit customized, then you will get the answer. The second one is OT bridge. I will let you know what is OT bridge. And third one is like the simple what we have learned it, key and keyway. When you have a like normal crown and bridge, we do a key and keyway the same way we can do a key and keyway. But only difference is like we have to do a rigid connection in this. So in particular case we selected the key and keyway. So what is that? So first we create distal part which have a male part which is parallel with the anterior remaining three implants, and the female part which is sitting on that, and both part will connect it with one more screw. So now I have four implant with five screw. So four implant have their own screw and one screw to connect the split. So I will get the complete rigidity in my processes. So that's how we can like split it in a two part. Then we just fix the first part, distal end. And now we just insert the anterior part. So now it is, there is no space in between the last abutments. Is it snugly it will go inside of that, and then I will fix the remaining screw with the patient. So the same way intraorally we have done it, and this is the post-operative OPG of that case. Then nowadays so many like tilt concept and all, and patients are coming with the problem like some of the implant got failed. Now doctor only once chance they will see wherever the bone is there, they will place the implant, and now this kind of condition will come across most commonly. So in this condition we have used the OT equator. So like we have correct this. So what is OT equator? OT equator is by Rain 83. So like you have a click like a elastic tuck, and then you have to insert the screw. Okay, so this elastic will give you the correction up to 15 degree. So like example, you have a straight multi-unit, after that there is no degree correction, but after equator you will get the 15 degree of correction. So in this case we have used this equator with straight and angle equators. So like we will correct the angles and we'll get the passive fit. So example, like this is the case in which like we just insert this prosthesis which is stuck first like overdenture, and after that we insert the screw through the prosthesis. So we have dual retention as well as stress breaking effect inside of mouth, so we can correct both angle as well as the stresses onto the prosthesis. So this is the case. and this is a post-operative OPG of that case. The second option, like you can do a customized multi-unit. Okay, it is a good option, but to be honest, for our Indian cases, like patients, like they our all cases, maximum cases, what we are doing with the limited budget. Okay, and to create the customization multi little going to be costly, so this is the best option, but it creating this, it's very costly for our patient. Okay, but in this case we don't have any other option, so we have selected that. As you can see, one implant, already two implants are placed, there is no bone or posterior sides, and one implant it's failed, so we have to take out. The another implant is connecting with the both cortical bones. If I take out, I will lose lot of bone and I have to place implant down. So to avoid that, we utilize that implant and we fabricate the custom multi-unit abutment. Okay, we design and we fabricate the custom multi-unit abutment, and this company don't have the 45 degree of multi-unit abutment, so we have to do a customization. So we customize it, complete customized multi-unit we have to do it, and then we create the screw retain bar on a top of it with the friction fit. So this is the bar with the VS3 attachment. So this is like just demonstrate to the friction based processes with the attachment. So initially we are not giving the female portion of attachment, we just give metal friction. As you can see, just little we press it, and if I want to take it out, it will give a lot of efforts to take out. Okay, so it's like a friction based, like a telescopic. So we initial time, we 1 year we do it. After metal to metal abrasion, it will loosen up. We insert the female housing and then we stabilize it for that. So you can see this denture, and this is the provision of metal housing. So like female insert, we can do it later on. So that's how we deliver this complete processes to them. So now which uh, animal you are able to see on a screen, just you can text me or you can message on that. Okay, so as I told you, like which animal you are seeing, so everyone is looking for animal. Okay, like the rabbit, but if you see this image perfectly, there is bird also inside. Okay, but I didn't ask you about the bird. Okay, so that's the thing, the company will give tell you always like you should use the company abutment, and you will not get the problem. But you know what, if you use it, definitely whenever you have perfect plan or perfectly executed that things what companies recommended, but if it is not there, then you have to think differently. Okay, so that's just one message I want to give you. That's why I have just placed this image inside of my presentation. So give you example, one two multi units I have placed. Okay, but the maximum what I got from the company, I have used it. Okay, now if I want to paste the processes, so my black line is first path of insertion, finish line of abutment, and the red one is second one. Okay, so my path of insertion of second in multi-unit is in a green part. So if I want the same part, then I will get the passivity, but I got this. Okay, and if I will insert the screw, it will tilt on that side, and when forcefully I will insert the screw, it will screw, but it will give a lot of forces on a one wall of a screw, and the another wall you can see on the image, it's not touching to the baseline of the processing and get fracture. So what we can do it, I will teach you with a simple example with the straw. Okay, if you have, everyone have see the straw fruity, one side is flat and another side is taper. Okay, so but both are cylindrical in a shape, both are cylindrical in shape. So what we have done it in this conditions, like we want this, so what we have done after that, we just add it in the software and then do it. So my screw channel, my direction, everything is same, but my resting position is different. So that's how the pathfinder application we have launched, in which like you can get the same path of insertion of all full mouth implant placement, even though it have a different angle, it's a customized path. Okay, so you will get the passivity in inside of your processes. and it is generated by AI software. So whatever angle is there, you can just give it to us and we can just modify it. So that's how AI software is working for us. So it will make parallel all implant and select the angle, and then it will modify the soft copy of what we have designed. So you can see the difference, the top portion what actually you are doing right now, and the bottom, the top part is going the straight, okay, in the path of insertion of multi-unit. The bottom part have an angle, so it will slicing of the path of insertion of that particular direction. So this is a difference between these two. Example, these all have a different path of insertion. Okay, so we just done a metal printing. Okay, and if you can see, we have sliced the landing area. The surface is sliced the landing area. So now all have adaptation whatever the angle is there, and the single screw will not create a problem. Everything is adapted inside of the processes. So after mucormycosis reconstruction, we got a lot of cases in which like zygomatic implant have placed and all have a different path of insertion, as maximum as possible 60 we can get. After that there is no correction. But using these applications, like we can correct up to 22 degree of after multi-unit. So and that is also you can make a parallel, and we have one single path of insertion for that particular case. So this is how we solve a lot of cases which have a different path of insertion with this application. The same way, I feel this is very boring for you. I have just kept some small funny story. Four dentists are there. They are discussing like which is better abutment, what to do, what not to do, and they have listened from the company, because at that time company only guiding. Okay, and there is no social media touch and all. So a company is giving, don't use the third party solution, and they have at that time use it with the limited sources, and they create the problem. Okay, at that time. So now there is a time going, they are guiding the next generation also, like you should use the company solution only, and they are following that. But the newer generation is coming, and they are seeing the problem, and the social media support, lot of corrections are happening in the prosthetic level, and now everything is digitalization. So we can do whatever we want, and we can change the concept of whatever they are inside of market. So the same way we have created this star abutment. So normally, if you have a hex implant inside of hex connection inside of implant, you can only rotate your multi-unit in 6 directions. Okay, but everyone know like it is difficult to get parallelism. You have to rotate the implant. You can de-torque it. Sometimes you lose the torque also, and you will not get the parallelism because you require a lot of little rotation to get the parallelism. To avoid that, we have converted our hex abutment into the 24. As you can see on a screen, the hex is converting on the 24, and the top part you can rotate in 24 directions, and the common screw will connect this two with the implant. So now you can rotate your multi-unit in 24 direction without rotating your implant. So that's how you can get the parallelism of that. And we have a provision of 2 degree to the 60 degrees, so like you can correct whatever you want the angle. So same way, like maximum people are doing zygomatic, they will not get exact parallelism, because zygomatic will go buccolingual as well as mesodistal two angles, and company multi-unit give you only correction with the one angle. So that's how just I'm presenting this case in which we have used the zygomatic guide and the same appointment prosthetic given. So this is with Dr. Nihal Patel. So opening the flap, placement of guide, dual lateral drilling, in the drilling, final drilling, insert the implant and place the multi-unit abutment. Okay, now in anterior implant we place the anterior abutments, and in that we use the star abutment, so we can make it parallel with the posterior to multi-unit implant. So after that we pick up the prosthesis. You can see they all have a parallelism. Just cut the extension and give a temporization on the same surgery. So this is how we got the complete solution for that case. After that, we want to create the final processes. So nowadays we have face scanner also, so we can utilize that. And using the face scanner, we capture complete jaw relation. Okay, so only part which is difficult in edentulous cases is jaw relation with the scanning. So we scan upper art, lower art, and the jaw relation we have done it with the face scanning. So like we can superimpose everything in the software, and we can do a mounting. We created the markers with the denture base and the face bow. Face bow also we can scan it along with the face bow. So like we can directly mount the digital inside of the software. And this is a digital mounting, and the right side is physical mounting. You can check the prosthesis, designing and prosthesis, and we can reinsert inside the mouth. So this how the technology evolved. Now nowadays there is no need of face bow, also there is a jaw motions. Okay, so like the software is capture the jaw motion, and we can create customized articulator for particular patient. So that's how the things are going on. So this is the complete result of that case with the star abutment. So like everything is passive even though we have used a zygomatic implant. So this is the last case which I want to present you, which is have a unique overdenture. The lot of mucor cases are there, and or maybe maxillectomy cases in which I am seeing they are giving obturators with the ball and socket joints or maybe bar and clip joints. But only problem is that this kind of cases like you have very less bone which is connected your implant. Okay, and a lot of things are cantilevering. Okay, if I will ask patient to take out that ball and socket over denture, it will give a lot of negative forces onto the implant because there is no bone support on the crestal area or to the implant. And the same way, if I'll have bar and clip, and when the patient is wearing it, pushing, so once again it will give a lot of forces onto the implant, and there is a maximum chance to implant got failure. So we use this attachment from Britain. It's called pin attachment. It's like your mobile slots. Like you have a SIM card, so you just place a pin. It slot will come out, and you can place your SIM card. The same way, it will help in the denture. So we can design this over denture. So this is a bar. This is over denture. It's 3D print and it's hollow, and it's easy to do it digitally hollow. So I just tell you how it's going to work. So this is my bar, have a hole inside of that, and the pin is going inside of that hole and lock the denture. So now my denture is locked, and now the key, we have to give key to the patient so they can just open the lock, and they can take out easily. So like this, so it will come out easily. So this is a clinical. This is a bar which have a hole inside of that to lock the pin. Then this is over denture locked. Smile, and this is how to insert. So you can see there is no compressor forces you have to apply to stabilize it. So there is no negative forces onto the implant, and just this locked. So now denture is locked. Now patient is taking out the opening the lock. So slot is given onto the denture like that. So like the key is directly slip in the inside that hole, and the denture will easily come out. There is no need to stretch or snatch it out. So it have very less forces on the implant. Then implant have a good survival rate. So this is the post-operative OPG of that case. And the digital technology like in which we can directly create obturator using the CT scan. So some of the cases in which like there is less mouth opening and you want to create obturator, so we can utilize the CT scan data. So in this case, there is less bone on a zygoma, so we decided to go ahead with the customized implant. So customized implant, and the defect is open. So we designed the customized implant, the bar, the obturator, everything is before surgery. So everything is ready before surgery, and with help of obturator the implant going to fix. So on a surgical day, just open the flap, place the implant, fix the bar, place the obturator, and then fix the screw with of implant to the bone. So it give a reference as well as position of implant while placement. So this is a complete case, and this is the post operative of that case particular. Same obturator we can give it to the patient. So thank you. Before finishing off my presentation, I just give you one story. Like everyone know this story, like on the first part, okay. But second, third, and fourth part is most important for our faculty. The first part is like definitely slow and study, like you can win the race in implantology. But second part, like Rabbit also get excited and he asked Luke one more race, okay. And the second part he won. So like learn from your mistake. It is most important part. You can learn from your mistake and you can go ahead with your work. The third part, like once again, Tortoise decided to do and he selected the track. Okay, now the tortoise win. So make your strategy according to your strength. Okay, you should know your strength, and according to you can plan your cases and you can deal the cases. You can use the system, everything according to that you can do it. And the last is like a combination of both. Like you can work as a teamwork. Okay, so if you work as a teamwork, you can solve so many cases. So thank you for listening me. Thank you very much.
Thank you, sir. So we have some questions coming up. Can we please take this up?
Sure, sure. So should okay. So should I close my screen sharing?
Sure, sir. Yes, will do.
Okay.
Yes. So the first question is, how do digital workflows enhance the customization of implant prosthetics to match the natural aesthetics of a patient's smile?
Yeah. So can I share my screen? One more. I have case. I can directly explain easily.
So, yes, sir. Sure.
So like the same way when what we are doing the smile design, the same way we have to do a smile design. Like the same data we want the uh, like photograph of patient upright and with the cheek detector and the smile, and the data like the CBCT data interval scan. Okay, we want it, and then we can start analyzing like what we are doing the smile design. So in this case, this is the pre-operative condition in which like we have this kind of condition in which we have a deep bite, okay, and which is not matching with the so this is the clinical condition what we got. So after that we take a photograph, we see the vertical dimension is lost or no. It is there is no loss, then we just take a normal smile photograph and check detail photograph, we superimpose, we plan, and we decided inside our software which the better smile, and we do a smile design. As you can see, we are finalized this position. Now this position we take it inside of the planning software, and then we decided the implant position. So is sometimes it's not permissible, so we have to look for the other option also we can do. Or in this case we got like we can flatten the bone and we can get the perfect position of my future prosthetic. So like same way as I told you, like the prosthetic driven, we have to do planning. So in this case, according to this occlusion, we done a prosthetic planning. So we require this much of bone flattening, as you can see on the left side top screen. So we done a bone flattening guide, and then like on a day of surgery, we just open, then we do a bone flattening, then drilling, insert the implant, then made multi-unit abutment, the pick up the prosthesis, and then we got perfect what we have planned it. And we pick up, we use the analog scan body to copy that prosthesis, and then we reinsert. So from here we have started, and from here we got. So this how you can directly design the smile of the patient. So this all data we require.
So next question is, hello.
Yeah, I can hear you.
Uh, so you can hear me, right?
Yeah, I can hear you.
Uh, so what are some potential challenges or limitations associated with digital implant prosthetics?
Yeah, so a lot of things are there. As I told you, the three challenges are there uh, on a three parts: scanning, designing, and the manufacturing. Okay, and fourth and most important is budget. So in Indian scenario, budget is also like how much you have quote to your patient. That is also most important part. So in scanning, okay, which kind of case you want to scan, according to that you have to decide your scanning protocol and the scanned components, like, okay, and that scan component will support which kind of design. Okay, that is also important. Then from that design, which machine you are going to utilize for the manufacturing. Okay, example, like you have code very less and your this one the case requires a lot of customization, then it's difficult for you to spend a lot of money behind milling the processes and all. So that all three factors have a lot of criteria to do these things.
So next question, how does the combination of metal and acrylic in dental implants contribute to achieving both strength and aesthetic flexibility in prosthetic restorations?
Can you repeat the question?
Yes, sir. So how does a combination of metal and acrylic in dental implants contribute in achieving both strength and aesthetic in prosthetic restorations?
Yeah, so it's a good question. First of all, what we are recommend when you have occlusal plane to the crestal area, metal acrylic prosthesis only we are recommending it. If it is not there, we are not recommending that. The second thing is like the three kind of things we can do it. One is like multi layered PMA available, so you can mill it and you can get the aesthetic. The second thing is like there is a lot of digital workflow also is there, in which like you can use a ready-made teeth cell which is available from the company to manufacture your processes, along with the digital, like the frame you will get completely female part on which you can just directly loot your shell. Okay, it will available in like a veneers. Okay, you have to just loot it, and it is from the Brident and the Ruthenium, both companies providing that. Okay, second thing is that, and third one is like we have option of the composite layering also to give a more aesthetic. So these three things you can do it in that scenario when you give aesthetics in like metal acrylic prosthesis.
So next question is it better to start learning with the existing or the digital implant?
Better to start, yes, definitely. The all actually in market right now, all the system have their own digital solutions. So definitely, if you uh, like, to be honest, if someone want to start now, for manual technique as well as digital, both are different field. Okay, but the manual give you a lot of idea, like what all concepts are there, lot of how to do it, the criteria of selection of implant to processes, everything, and then you can utilize that knowledge from in the digital. But to learn the digital, it's for new person also it's new, and who is working in implantology, for them also it's new. Okay, so yeah, basic in anything, like example I have given, like if you want to write the letter, you know how to write the letter first. Okay, so basic you know, then you can write that same thing in your mail to send the letter. So basic you definitely you required.
Okay, so one last question is some key principles and techniques involved in achieving stable fixation of a master guide during the guided implant surgery.
Three step of
some key principles or techniques involved in achieving stable fixation of a master
Yeah,
dial.
okay. So three techniques are there. The first technique, like already explained, like we have a lot of teeth are present, and you are going to extract the teeth, and you want to stabilize the guide. Then you preserve two or three teeth, and you can utilize that 3 points to stabilize it. The first point. The second point is like you can open the flap, and you can directly do a guided surgery on bone level. And third part is like you can use a mini implants, which is there available, like ortho implants or mini implants. You fix it in a place like midline and the above the mental foramen, and just go for the CBCT and utilize as a stable structure to stabilize your guide if you don't want to open the flap. So this is the thing. See, this is the things we can get it for stabilize. And the fourth one is like someone like me, like I am a prosthodontist, so I don't want to open the flap completely. So I can create three islands. Okay, just three islands in the guide. So like three area only, I just minimal opening the flap and utilize that bone to stabilize my guide. So that's how we stabilize the guide onto the three stable structure which is connected with the bone.
So I think that's all with the question of the session. So
Sorry.
that's it. Like we have no more questions coming up now.
Okay.
I want to thank you and for exceptional presentation and making this webinar a success. Thank you so much, sir. Your
Thank you.
extensive knowledge and innovative insights have really inspired us and has been really invaluable to us. Thank you
Thank you.
for taking out time, and we deeply appreciate your effort, and sir, and we're looking forward to have the opportunity to collaborate with you again in the future.
Sure. Thank you very much.
Thank you so
Thank
much,
you.
sir.
Thank you.
I now welcome Dr. Sunny, who's from Tutsi and will be taking over now. Hello, Dr. Sunny.
Yeah. Hi, Dr. Snail. Very good afternoon, everyone. Hi, this is Dr. Sunny Sinha. I am a practicing orthodontist. I've been practicing in Mumbai since last 10 years. I also look after the treatment planning department of Tutsi. So now I have been given this opportunity of uh, presenting you a basic idea about aligners. This is a very limited time slot of 15 minutes. So I would proceed. This is kind of trailer, but trailer hai, picture abhi baki hai. You can connect for the picture later on with us for a extended webinar or a training session. Let me share my screen.
So
Yeah. So see, in last 20, 30 years, we have seen the world changing a lot. It has become completely digital, and so is dentistry. That is why we are promoting digital dentistry here. Now, similarly, the world of orthodontics also has changed a lot. When we started with metal braces, then came ceramic braces, self-ligating braces, lingual braces, and now it's aligners. Why? Because there is a need. There is a need to look good. In today's world of Insta and Facebook, nobody wants to compromise on their aesthetics. Actually, aligners were started as an alternative for adult braces. But nowadays, even kids and teenagers are more and more aesthetic conscious than you and me.